Yeah, we've studied the sick JAK inhibitor, sertolatinib, and we've treated a few patients and seen some responses, but it's still way too early. We're combining all these things. I mean, it's like the old days. We took all the chemotherapy drugs and did cytobomb makeup even. Now we're doing that with all these targeted drugs, and there are hundreds of studies of doublets and triplets of checkpoint inhibitors and BCR signaling. How do we pick what drugs? How should we pick what drugs? How can we pick what drugs to combine with what drugs? Right now it's totally empiric.
It's very empiric, and unfortunately, because there are no good models to predict toxicity with some of these novel combinations, and we've seen many studies in the past 5 years which have been terminated due to excess toxicity.
Several of them were mine.
Yeah, and ours too. I mean, we had lenalidomide adalimumab, which was closed just this last month. We saw letters from the FDA going out with combinations of pembrolizumab and lenalidomide in myeloma, which unfortunately there was excess mortality in the combination arms. So today, I think...
And that's had spin-off to the durvalumab.
Correct. Yeah, so it's spinned off to, unfortunately, well, I think it's a good thing to do, it's a safe thing to do, but across the field right now, we're seeing a kind of reevaluation of these combination immunotherapy studies in B-cell malignancies, as well as in myeloma, until we can really kind of figure out how to predict toxicity and reduce risk for patients.
You've thought about this a lot?
So I think it's a very good point. I think the biggest challenge that we have is how to prioritize, how do we pick as investigators the next combinations, and there's plenty of them floating around. It's a phenomenal number of combinations you can do, not just true novel. There's a Me Too drugs, multiple checkpoint inhibitors plus certain drug. How do you choose which one you want to work with? I think the best idea, and I think it's not easy, is to step back and perform this synergy analysis in independent laboratories, and then prioritize which one has the highest chance of being beneficial or synergistic. There's no question that there's many combinations will give you some benefit, but is it the right combination that we want to prioritize? And I think there may be one better than others, and we should seek it then as a group or as a community and say, this is the combination that we want to pursue. Thank you for offering combination C, because I want to focus on combination A. Otherwise, it's going to be messy. We will be doing a lot of trials, competing with each other, and we will not be able to finish these trials because of this competition.
And there's another risk we're running into here. And I remember the old days when you were young and you were...
I was way young. I was way young.
You were way young.
Yeah.
And I was at a cooperative group meeting when I was still at the NIH, and I was listening to them. They'd already done studies with doxorubicin in large cell and epirubicin in large cell, and there was another rubicin, and I got up and I said, really guys, can't you think of anything different? Now we have 5, 6, 7 BTK inhibitors, 4 and 5 PI3K inhibitors. We got a swath of anti-CD20s. I don't want us to get in that position again where we're just doing Me Too studies just because the different company will give us their targeted agent rather than the other one.
That's right.
I think it's a risk we run into.
I agree.